I will be talking about acute primary herpetic gingivostomatitis. For an overview, herpes simplex virus is a double-stranded virus belonging to human herpes virus family. And although it exists in 8 various forms, herpes simplex virus 1 causes most of the oral infections. And since dentists are more likely to be consulted in the case of oral infections, being familiar with these lesions becomes mandatory. It is more commonly reported in children and rarely in adults. Now, herpes simplex virus type 1 and type 2 are responsible for primary and recurrent mucocutaneous herpetic infections. Herpes simplex virus 1 is predominantly associated with orolabial infections, while herpes simplex virus 2 is predominantly associated with genital disease. The two forms of herpes simplex have a similar structure, but herpes simplex virus 2 is of greater virulence. Most of herpetic infections are transmitted from infected persons to others through direct contact with a lesion or infected body fluids, for example, vesicular exudates, saliva, and genital fluids. Clinically, herpes simplex virus 1 begins with prodromal symptoms, such as fever, loss of appetite, malaise, and myalgia. And within few days of prodromal symptoms, erythema and clusters of vesicles start to appear on hard palate, attached gingival and dorsum of tongue, and non-keratinized mucosa of buccal and labial mucosa. Also on ventral tongue and soft palate. Now vesicles break down to form ulcers and they coalesce to form larger ulcers with scalloped borders and marks surrounding erythema. The gingiva is often red and mouth is extremely painful, causing difficulty in eating, and the patient reported in this case that we're going to talk about has all of these features. This is the clinical presentation of acute primary herpetic gingivostomatitis. You can see the gingiva, you can see the papules, the ulcers, the redness. It's important to distinguish primary from recurrent herpetic infections, and history may be helpful in distinguishing primary from secondary infections, as patients with a secondary infection will recall previous episodes of vesicular eruption on their lips. Now, treatment modalities include nutritional supplements, analgesics, and antiviral drugs, such as acyclovir, which is available in cream and oral suspension, valacyclovir, and famciclovir. Case presentation. In this case, it's reported for a 32-year-old man that came to the outpatient department with a burning sensation in the mouth that worsened on eating hot and spicy food. He gave history of ulcers in the entire mouth since 2 days. Medical history revealed that he was suffering from fever and generalized weakness. He had not taken any medical or dental treatment for the problem. Family history was unremarkable, and on intraoral examination, gingiva appeared red in color and multiple vesicles were present on the attached mucosa. Pictures will be in the following slide showing the clinical presentation for this case. And also he had multiple vesicles and ulcers along the lateral and anterior surface of the tongue. And on the basis of these clinical features, diagnosis of acute primary herpetic gingivostomatitis was made. Looking at these pictures, in picture A you can see multiple vesicles on both keratinized and non-keratinized mucosa, and the gingiva is red in color. In picture B you can see multiple ulcers present along the lateral border and anterior dorsal surface of the tongue. In picture C and D you can see multiple vesicles and papules that coalesced in large map-like configuration on the right buccal mucosa. Investigations for this case. The diagnosis of primary herpetic gingivostomatitis is generally defined by clinical data, and no confirmative tests are necessary. The available investigations are viral culture, which is considered the gold standard and the most sensitive of the diagnostic techniques, but it's generally limited to the hospital setting. Direct immunofluorescence, TASNAC test that demonstrate multinucleated epithelial giant cells which are consistent with a herpes virus infection, and it generally detects only about 60% of herpes simplex virus infections. Smears also yield no information as to whether the viral agent is herpes simplex virus 1, 2, or Varicella zoster virus. Differential diagnosis for this case would be recurrent herpes simplex infection, major aphthous stomatitis, and erythema multiforme. Now for treatment, the patient was instructed to eat nutritious soft blend diet and the following medications were prescribed. Acyclovir 200 milligrams 5 times a day to be rinsed and swallowed, benzidamine hydrochloride mouthwash, analgesics, and antipyretics to address fever and malaise. Outcome and follow-up for this patient. Now, this patient responded well to the medication and complete healing was seen after 2 weeks as seen in the picture here.